This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the MitraClip as a treatment of the leaky mitral valve. With me today is Mustafa Ahmed, who's director of the Interventional and Structural Program at the University of Alabama in Birmingham. And believe me, he has a lot of experience on the MitraClip. We know that there is an unmet need for patients with mitral regurgitation. It is estimated approximately 2 million people have severe mitral insufficiency just here in the United States, and probably about 1 million of them are at high risk. We have an annual incidence of over 300,000 patients with new onset of mitral insufficiency that is severe. And if you look at the mitral valve surgery, only 55,000 surgeries are performed in the United States. That's approximately 3% of all of the patient population with mitral insufficiency. In 2019, we had about 10,000 clips performed. So the MitraClip, or the endovascular repair of the mitral valve, or using the edge-to-edge technique, is relatively new and very user-friendly for the patients, for the centers that are very experienced in performing these type of procedure. And we're looking at a very specialized structural program. And Dr. Ahmed is head of one of those programs. And so, Mustafa, if you could tell us a little more about what is the MitraClip and how does it actually work, on the mitral valve, and how do you perform those procedures?
So the MitraClip is a technology for treating a leaky mitral valve without having to undergo surgery. And really, why was this developed? This was developed because although many patients can undergo surgery, there is a particularly high-risk group of patients who, may not be suited to have open techniques. Even when surgery is minimally invasive, it still is a lot for patients to undergo. And so the development of what we call percutaneous therapies, which means, we go through the leg, we don't do an incision, we don't put patients on the heart-lung machine. Those are the kind of therapies that have been developed, which have seen the new age of treatment occur. And the MitraClip was the first major advancement in the treatment of a leaky mitral valve, which involves going through a vein in the leg and putting on a clip onto the valve to allow it to come back together. So there's two kind of sides to the valve, the anterior and the posterior side. And the clip attaches, one part of it to the anterior, one part to the posterior, and it's almost like a clothespin. By the time it comes together, it keeps both the anterior and posterior leaflet together and has been found to be a very effective way in suitable patients to minimize the leak, improve quality of life, and the more and more we learn about it, can prevent death, hospitalization from heart failure, and has really turned out to be an important tool in the armamentarium for treatment of mitral regurgitation.
So how is it performed? Is this in the cath lab?
Now it is almost universally performed in cath labs. Some people use hybrid suites, so kind of a little more of a advanced cath lab. But current cath labs with their imaging platforms can very, very safely perform the mitral valve clip. It's interesting because we perform the MitraClip in the cath lab because we use fluoroscopy, but actually, which means X-rays to guide where we are. But actually, the MitraClip is a very imaging-based procedure. And so the most important part, of the clip in general is the imaging. There's a procedure known as transesophageal echocardiography, where a small camera is put down the throat as part of the procedure, which is why, the overwhelming majority of these patients are asleep when we do it. And those pictures give us crystal clear, particularly since the invention of 3D echocardiography, they give us crystal clear guidance on where to put the clip, how, whether it's been effective or not, evaluating the result, and just guiding the whole procedure. So it's a very imaging-based procedure, but can be done safely in the cath lab.
So basically, you have this little device that basically grasps the leaflets of the mitral valve, the anterior and the posterior, and you're able to basically reduce the amount of mitral insufficiency. Is that pretty much the goal of that procedure, is to reduce the severity of the mitral insufficiency?
Yes, well, the goal of any procedure really is to say, how do we improve outcomes for this patient? So the real goal to keep in mind, it would be pointless to have a procedure that reduced the leak but made the patient worse, or reduced the leak but, didn't lead to any improvement in outcomes. So, what we're looking at is how can we improve quality of life for patients, and if possible, extend length of life and reduce hospitalizations, maybe need for medications, and other surrogate outcomes like heart function. But really all of this is based around can we reduce the leak? Of course, valve disease is a very mechanical type issue, and the reduction of the mitral regurgitation is the center point of the whole therapy. So when we do put a clip on, as a proceduralist in that procedure and in that room, what you're aiming to do is to reduce the mitral regurgitation to as low levels as possible. Now, I'll tell you personally, when doing a procedure, we want to, if at all possible, and if it makes sense, to try and match the surgical type results of no regurgitation left or trace regurgitation left only. The evidence for the MitraClip in most things, most of the studies and registries done, shows the benefit really starts to kick in when you can reduce the mitral regurgitation by a few grades. So grade 4 is really severe, grade 0 is non-existent, and grade 2 is kind of the line which seems to separate people that have significant and non-significant mitral regurgitation. We know with the clip that any grade of reduction of mitral regurgitation leads to improved outcomes, but really those are seen once you start to get to the 2+ and below range. But at no point should people doing this procedure see that as a signal not to get the best result they can. Really, we should be going into those rooms, and experienced teams really are aiming to get the leak almost down to 0 if possible. And a lot of experience and the kind of team performing the clip are central to letting that happen.
Right, we're going to try to zero in a little bit on the patient population. And if we go through the evolution of the clip, we know that in 2003, the first patient was done, and the mitral valve regurgitation was fixed with the clip. 2011, it took that long to develop that technology. 2011, it started becoming a very important pivotal trial, the Everest-2 clinical research trial that started in 2011 and was concluded in 2013, and really compared the clip to the mitral valve repair. Can you tell us a little bit, Mustafa, who were the patient, what was the patient population, who did they study, and who was a candidate for that clip versus the repair at that time?
Most people, when you're giving a lecture on the MitraClip, you start by saying, okay, what we're trying to do here is, who came up with this idea to put a clip on someone? Why are we putting a clip? Why are we even trying to do that? Well, how do we even know that would reduce the regurgitation, right? Because it's not similar to how you would do a normal mitral valve repair. Dr. Alfieri, a very, very famous surgeon who initially came up with something called the Alfieri stitch, or I believe he initially came up with what we know as the Alfieri stitch. And that really said, we're going to put some stitches in between the anterior and posterior leaflets, bring them together, and lo and behold, the leak was reduced effectively in many cases. And that was the basis underlying the development of the mitral valve clip. Can we do that same stitch, but can we do it percutaneously through these, catheter-based methods? And a lot of excitement, particularly when in early models, it demonstrated, hey, we can reduce this leak significantly, but we can definitely get a clip on there. We can make this recreation of the Alfieri stitch happen. It's not exactly, semantics. It's not exactly the same, but it's the same kind of thought process. And so we know it worked, and it had to be proven in trials. And so the first landmark trial, as you mentioned, is the Everest trial. The Everest trial did look at a lot of different patient groups, but really the group that we came out of it with the knowledge that we can proceed and help people is for the degenerative mitral regurgitation groups. That means those people where the valve itself and processes such as mitral valve prolapse, leaflet thickening, and not just a bad heart leading to a bad valve, but really a bad heart valve itself as a mainstay in what we know as primary mitral regurgitation, as opposed to the different one, which is functional mitral regurgitation. So the Everest, and I will tell you, the more you look back at Everest and see that that trial got through, the more incredible, because when we do CLIP today, it is night and day. It is like driving a car that's made in 2020 versus driving on a car that's made in 1950. I mean, the CLIP, believe it or not, the CLIP technology itself hasn't changed as much, but the imaging, what we know, the understanding, the operator experience and the volume. So it's night and day what we have now. I have almost no doubt at all. If we went back and did the Everest trial now with what we know, it would just be so overwhelmingly different in terms of the results achieved. But the fact that that trial still went well, despite a group of operators who, did not have the experience that we have now, just is an astonishing thing. Just historically looking at trials, the pristine 3D images we have now were just grainy 2D images, and it was a great effort. But we came out of that knowing that when you take a high risk population and you compare them to surgery, and I'm not talking about the early failures. There's always some early failures back then that would need surgery. But when you take out those people, particularly that you had a successful CLIP result, it was not inferior to surgery over the long-term follow-up or the intermediate term follow-up. And we've learned since then the long-term follow-up. And it did provide a way of taking the sickest and, the ill patients, the ones that we really didn't want to operate on. We now had the beginnings of evidence that the MitraClip can reduce the leak, the patient can do well over the long term, and we can avoid, the brutality of having to do a surgery in someone that's really not a good surgical candidate. And that's where it was kind of born. And that was a landmark trial, the Everest 2.
It was interesting to me that there was no difference in mortality, between the CLIP group and the group that had surgery. Of course, there was a better resolution of the mitral insufficiency or mitral regurgitation with surgery. But it seems like, particularly in the first year after the CLIP, there appears to be some increasing problem with hospitalization and having to do some redo surgery or more procedures. But if you look after a year, there was no difference in terms of heart failure hospitalization or having to do another surgery because of the mitral regurgitation. So pretty incredible. So the FDA obviously approves the trial in 2013. And also what is interesting to me is that there was about a quarter of the patient, or 25% of the patient, that had secondary mitral regurgitation in that group of Everest 2. But that led to obviously a very important trial, the COAPT trial, presented in 2018 by Greg Stone. And to be honest with you, I've never seen this in a national meeting of cardiology, having a standing ovation when he presented the results, because it was quite remarkable. It took 6 years, to conduct the COAPT trial in patients with secondary mitral regurgitation. Mustafa, do you want to tell us a little bit more about who were these patients with secondary mitral regurgitation that were entering the COAPT trial, and what were some of the results?
Yeah, as you said, the COAPT trial, a great effort, a strikingly positive trial in terms of its outcomes, a trial that was very, very difficult to enroll in. Mainly because the entry criteria was stringent. And that was probably very important because it then allowed us to recognize this could be a therapy for people with secondary or what is known as functional mitral regurgitation. So this is different to primary. Secondary means the heart is bad. These people have had insults to their heart that have made it worse over time. And that has led to the valve becoming deformed or distorted, leading to the leak itself. So now we needed to show evidence that we could help that group. It's a much larger group of patients. It's a group of patients that we as busy clinical doctors come across routinely, and for years have been looking for a treatment for them, but also to start the beginnings of answering the debate: should we treat the heart? Should we treat the valve? Should we treat both? And so this trial came out, which took years, again, because the entry criteria were very stringent. And this showed that use of the MitraClip in that functional population that had been allowed to enter the trial because they had been treated with every possible medicine that they could take that would help the heart to heal. Those patients that had what we call a non-synchronized heart had the pacemakers to make them synchronized again. They had been seen by heart failure specialists and their volume of fluid status optimized, because we all know that can, definitely strongly impact the degree of mitral regurgitation. So we've really gone out of our way to do what we can to treat everything but the valve in that situation, and still the valve is really leaky, leading to symptoms of heart failure, hospitalization, death, and other things. That the clip came along and had just, again, an astounding, I was there actually, it was an astoundingly positive, very strange, right? How everyone suddenly started clapping and standing up.
I've never seen that.
But I think because everyone's just been waiting for so long to see what this happened, and also probably because a bunch of interventionists were sitting around thinking, "Oh gosh, there you go, we're about to get a green light to go and use this therapy to help people," and so.
Let's remember, it was right after the release of the mitral FR, the European trial, that didn't show any difference.
Of course, that put an immediate dampener on the fireworks that went off. But really, that trial was a randomized, controlled, multi-center trial that did demonstrate, with a good level of evidence, for as far as a single trial can be, that the MitraClip could really impact the lives, survival, and quality of life of people with functional mitral regurgitation.
So these were, in the COAP trial, these were secondary mitral regurgitation with moderately to severe MR, whether they had a cardiomyopathy that was ischemic or non-ischemic, but their ejection fraction was between 20 and 50%. But a lot of them, it was mostly, obviously these were patients that failed medical therapy. Granted, remember this was years ago, nobody was on Entresto. So we didn't really have quite the optimal medical therapy, but we had what they had at that time. But it was pretty amazing that all-cause mortality were reduced. In the group of the clip and medical therapy, it was 29% versus 46%, in the medical therapy group. Substantially improved quality of life, and over a third of them, 36%, versus only in 17% in the medical group. So we have our patient population, a patient for the clip that are either primary mitral regurgitation that are at high risk for surgery. It seems like the result is as good as the surgery. We have also even some patients with secondary mitral regurgitation when the heart is sick. But when you have the heart is still not that sick, that you don't have these huge dilated ventricle, but you have that very severe MR. I think these seems to be, the candidate for the mitral clip. And it's really nice to see, the evolution and how much the clip has been used. If you compare 2013, when the FDA, approved the clip, there was 99 centers and 1,000 clips performed. In 2019, last year, almost 400 centers are performing mitral clips for a total of patient over 10,000 patients. So tell us, in your mind, in your center, who is the ideal candidate for the mitral clip? If you kind of look at not only the patient population that we discussed, but also if you look at the mitral valve itself, what makes you believe that this would be a good candidate for a clip?
Well, just to backtrack from what we talked about before, why was everyone so extraordinarily excited about the results of that trial? Because the number needed to treat, right? So the number needed to treat is something we use in trials. Many medications that we use in heart disease, the number needed to treat may be 50 to save one life or to prevent one event. When in this trial, the number needed to treat was literally just a few. Really, what you're saying is you treat just a few patients and you'll be able to reduce mortality, hospitalizations. And I think that was it. The Kaplan-Meier curves, these curves which we look at, which were separating, there was such an amazing divergence and difference in those curves that was just so striking. And I think that led to a lot of the excitement. I will tell you about valvular heart disease. Now, I started looking back at valvular heart disease, years ago. One of the first things I ever had to do was an extensive review on the topic. It's a funny story because when I got to the United States, my mentor back then was like, oh yeah, I'm going to get you involved in the project. He's like, you've got 2 weeks to do it. And I was like, that's great. There's 2 weeks. What he didn't tell me is it was like a 100-page booklet which needed to be done, which is an extensive review article. And in those 100 pages, one thing I did learn is the level of evidence, level of class 1 and class 2 evidence in valvular heart disease, it was minimal. We really had a bunch of guidelines that really were not informed by evidence. And then TAVR came along with aortic valve disease and demonstrated, we can put these TAVR valves in and striking improvement in quality and mortality, But then MitraClip came along. And again, it was just this advancement of treatment of valvular heart disease. And that's another reason why everyone was just astonishingly excited. It's bringing valve disease into the 21st century. And that's what it was doing. Just the trial alone, not to talk about the results or how we should extrapolation, but just the fact it was pulled off and the effort was being made. That's what made that trial such a big deal. And so when we talk about who do we do as our usual patient, so the big word, the most respected word is heart team approach. So no patient should, in this day and age, be going to be evaluated for just a MitraClip or a valvular heart therapy. When a patient comes to see us in our valve center and with mitral disease, our first thought is not, oh yes, let's do a MitraClip because they've been sent for a MitraClip. The first thought is, how do we accurately diagnose, quantify, and understand the mechanisms of this disease? And the mitral valve is extraordinarily complex. So the first part of the evaluation is you want to be able to bring your patient and say, okay, this is severe MR as determined both quantitatively and qualitatively, which means we've used both routine and more nuanced mechanisms to do that. And that may involve transesophageal echocardiography, normal echocardiography, three-dimensional echocardiography, magnetic resonance imaging, and even heart catheterization to really understand and say to ourselves, this is severe or non-severe disease in nature. Now, after that comes mechanism, and a lot of that is informed by, these imaging. Is this primary? Is this secondary? Is this valve repairable? Is it not repairable? Is it replaceable? Is it not replaceable? Is it even doable by percutaneous methods? Which means how much calcium is in the valve? What does the leaflets look like? If you're going to do a clip, you look at an image. We've done so many now. You can kind of look at an image and know, but it's not that you know it. It's through the experience that is the posterior leaflet long enough, short enough? Is there calcium? Can you grasp that? What's the subvalvular structures like? How wide is the mitral regurgitation? Are you going to leave the patient with it goes, oh, it's tight valve or not? And it goes on and on and on. The biggest mistake I see happening is people treating people that genuinely don't have severe disease. And so when you are evaluating their images that really know what they are doing and are independent of bias, used to confirm the presence or absence of that disease. And it may be it's the other way around as well, because you may have people with not so severe disease that is dynamic, which means once they start to become active, the symptoms become much worse because the leak comes when the patient is put under stress. So first we do that. And then you get with your heart team. So you've got mitral regurgitation. There's 10 options should be on the table, not one. Again, the mistake is to say, oh yeah, what a great candidate for mitral valve clip. So it should be, can this patient go open surgery? Can they undergo minimally invasive surgery? Can they undergo robotic surgery? Should they have a mitral valve edge-to-edge repair with something like the MitraClip? Should they have a mitral valve replacement? Should they be considered for new trials of new technologies coming in? And unless you have all those options present, you're not doing service to that patient, because then we're doing a one-size-fits-all approach. But there's nothing more different than a one-size-fits-all approach in the nuanced and contemporary management of mitral valve disease. And so that takes a good imager, a really good surgeon who can repair a valve that needs repairing, because what is done a lot is valves are replaced when they should be repaired, and a team, a percutaneous or structural team that's very fluid in the percutaneous options and is willing to send their patient where they need to be sent, whether it's you do the clip yourself, or you send that somewhere for a trial, or you send it to the surgeon because it should be repaired. And until those competing interests are removed, there's always going to be people that are done a disservice when going to valve centers. So a good contemporary valve center has all of the above, working fluidly together, taking a patient and navigating them to what is the best option for them. Is the risk high? Is the risk low? Simple classic conversations. Let me just take a few patients from the last week. So there'll be one patient where, I think the surgeon sent it. So this is too high risk. Do you think you can clip it? And I would say, no, I don't think a clip can go on there because there's calcium here. The posterior leaflet is this. We'll leave the patient with a tight valve. I don't think we'll get a good result just based on multiple anatomic factors. And then we say, you know what, we're not going to do any of the above. We're going to send our patient for a consideration to be in a trial to see if we can do a non-surgical approach to mitral valve replacement. And then there'll be patients who come in and are sent, it's always disappointing for a patient. They'll come in in their 60s, relatively healthy, and they'll say, I really want a mitral valve clip. And I'll be thinking, you know what, we could probably do that really easily, but your best long-term option absolutely is to undergo surgery. And we happen to have a surgeon that can do it minimally invasive robotically. And that is the best option for them. But then we take the patient with, higher risk that has the anatomic suitability to undergo mitral valve clip, that absolutely does have severe mitral regurgitation and has been maximally treated with medicines if required. That is your patient that can then undergo the mitral valve clip. And even with the clip, once you do the clip, particularly in functional, if you haven't optimized everything, your long-term result is unlikely to be good. We certainly have no evidence that your long-term result can be good. So all those things need to be taken into this heart team approach that brings your ideal patient, but it's still high risk, or obvious reason not to do a surgical approach in patients with a MitraClip. And sometimes there's patients that the surgeon knows they can't repair the valve. And so I might have a conversation with our surgeon that would say, hey, I think you're going to replace that valve. And he'll come back to me and say, I really do think you should have a go with the clip. And if that doesn't work, then we might consider mitral valve replacement. Again, we would only try that if we genuinely thought we could get a clip result. But that's an example of a heart team that's really putting the patient at the center of the whole conversation.
That's very important. You mentioned, the high surgical risk. Can you elaborate a little bit on this, Mustafa? What do we consider a high surgical risk? That would make you a candidate for a clip.
So high surgical risk would be firstly, I'll say eyeball test. I mean, that's really what a lot of this comes down to. You'll see someone and you'll say, there's no way that this is a good idea for this patient to undergo surgery. It may be due to comorbidities, frailty, age, multiple previous surgeries, just things that become very apparent. The method of making this more scientific or binary is to use something called an STS or Euro score. And these are scores that have been developed over time. And high scores may pertain to a high surgical risk. So you put a bunch of variables into the risk calculator, age and kidney function and heart function and previous operations and all of this stuff. So many variables go in and calculate a score. And scores, above 6-7% maybe super high risk, and above 2-3% maybe intermediate risk, and 1 to 2% less than that maybe low risk. But that's good because, again, different teams have different experience. Just because a patient is high risk in one center doesn't mean they're high risk in another center. And, the scoring, the eyeball test, and then there's just other obvious things. Like you might have a good score, but then if your patient's lungs are so bad that they're not going to get off the ventilator after surgery, or the kidneys are so bad that when you go and do surgery, you're going to put them on dialysis straight away. Or the ability to rehab is so low that they're going to undergo surgery and they're not going to be able to rehab because they're already in a condition that doesn't allow that. Those are, again, patients which you would say, as a heart team, that patient should not go surgery unless it's the last resort. Let's try and look for an option such as mitral valve clip. So, it's the experience of your team will govern that, as well as all the factors we just talked about and the options available.
So, yeah, and probably should add in patients with liver disease, you should not undergo surgery. From the point of view of the valve itself, I mean, you mentioned the calcification and probably also when the leakage of the valve is central, but you have some patients sometimes that present with very eccentric jets, which could be on one side or the other. Does this affect your treatment or your evaluation for a clip?
The presence of an eccentric jet alone does not. Again, what's causing that? This is where mechanism comes into play. If it's a degenerative portion of the valve causing the eccentric jet, what does that mean? It means that the leak's not your classic leak going up. It's kind of going off to the side, could be underestimated, overestimated. But again, that's where imaging is so important. A good imaging study will tell you this jet is eccentric because of this leaflet being prolapsed or flail, or this leaflet being deficient in some way, or this leaflet being retracted. And as long as you can pick that up and then look at factors of the leaflets, is it long enough? Is there width? Is there graspability? Is there not? Is there calcium? What's the durability? Looking at all that over the course of an evaluation will be able to tell you, doesn't matter what kind of jet, you possibly can treat it. There's different levels of treatment. Not every clip center is equal, just because of experience available and experience over time. And so most clip centers can do something which we call, down the middle kind of clip, A2, P2. Those are the two central things, technically easier to get to. And then as you kind of get more experience, you go into the commissures, which mean the sides of the valve, so the middle or the side, and you start to it's a bit more challenging anatomy because the apparatus below the valve is more complex and there's more stuff you can get caught in. So you need to really kind of be wary and cognizant of all that when doing that. But those can be done really well and reproducible. And then there's ones where there's calcium and there's this and there's a short leaflet, and you really, even an experienced clip implanter is thinking twice, talking to your patient beforehand and making sure it's the right option, or you may have a backup option or not. So there's different degrees of complexity. But what we have learned over time is, in most cases, even when complex, you can get good clip results, with an appropriately experienced team.
You mentioned the flail. This is obviously when you have one of the chordae attaching the mitral valve to the papillary muscle, or sometimes when you have even a rupture papillary muscle. Is there a degree of flailing that you're not able to clip with the current technology?
Right now, we have the latest iteration of the clip called the G4, and this has allowed something new, which is independent gripper dropping. And I'm getting a little technical here. But really, it has allowed us to go even one more step, wider gaps, coaptation gaps, higher flails. You can do that. What I will tell you about flails is I don't think there's a flail that can't be clipped now in this day and age, again, with an experienced team. But the long-term durability of those, you really need to ensure there's a lot of leaflet grasped. You may need to put 2 clips, sometimes 3 on in those cases. And you really want to make sure that valve can't be repaired before you go ahead and do this clip. I think the long-term durability of a hugely excessive flail is to be determined. What we do know is the intermediate-term durability, the ability to get your patient out of trouble there and then, reduce the leak and kind of go forward. Even challenging, flails with high flail gaps, flail widths, and flail kind of, the whole complexity of the valve, what we call valves, or just lots of other prolapsing segments. Even those can be done with decent results now. But that's got to go into your thought process. I mean, at no point should you be trying just to do that patient because you can get a clip on it. You should try and, if your surgeon says, I think I can do that pretty straightforward, there shouldn't be a conversation saying, well, I can get a clip on there, because the surgical result is going to last a long time. Whereas the clip result may last a long time, but you want to save it for the times when it's the appropriate thing to do in that setting. Talking about this, there is this ongoing study which we're about to be a part of called a Repair MR. And the Repair MR study is now looking at this in a much lower risk population. And it's going to be a very interesting study because there's all those people that see these good results in the higher risk. And they look at the aortic valve space and say, well, we took that from high risk to the medium risk to low risk and did that fine. Why can the clip not be done in suitable cases in people with a intermediate or lower risk? And so that is now ongoing. That will be several years in the making. We're starting the enrollment of that now in the United States. And that will tell us the answer to your question. But I really don't think we'll have the real answer to that question for a long time until we have the longer term follow-up.
Are there patients that are where a clip is contraindicated?
Yes, prohibited in patients with extreme calcification, high gradients to start with, which means you could make the valve too tight or mitral stenosis, in patients with pre-existing mitral stenosis, in patients with active infection endocarditis on the valve, in patients where the mechanism is actually something different, such as leaflet perforation or damage from something before. So yes, there are many cases in which you would not want to use it. Extreme calcification, deficient leaflets that are less than a few millimeters big and can't be grasped. So those are cases where, it's only going to turn out one way. And it's really important that this pre-screening process confidently identifies those patients and avoids doing them.
I think we've got a pretty good idea now who's a candidate, for the clip. You mentioned some of the benefits. Could you maybe, let's look at the risk versus the benefit, performing a clip. What kind of benefits do you get? What are the risks, that the patient can encounter with this procedure?
Yes, as in any procedure in medicine, the risks need to be discussed carefully, but the benefit needs to outweigh any risk. There's short-term risks and there's long-term benefits and vice versa. And the clip, for all intents and purposes, we're not stopping the heart. We're going through the vein and going across. The risks that can happen are damage to the blood vessels on the way in, which is as low as very low few percent. Damage to the heart itself while trying to get across the heart in a process called a transeptal puncture. But I will tell you, these are so common now and training so advanced now in many programs that the transeptal puncture now is no longer a rate limiting step in doing the clip. And the complication rate associated with that is much less. Simply because structural heart specialists now know what they're doing, that you shouldn't fear a transeptal now in the contemporary mitral valve performing the clip. And then, the risks really are you going to make the valve worse? Are you going to walk in and the leak be 3 and leave with a leak of 4? Are you going to tear some of the leaflet out? Are you going to leave a clip and it do no good and it kind of fly off? And those are the things that you want to look for. But if you do a good screening process, all those should have been identified before and those taken into account. So the risk itself is low, very low few percent for leaving the hospital and doing well. Your risk, of course, is always dependent on what's going into the procedure. If you take someone from home, admit them to the hospital for a one-day procedure, and like our patients all go home, within 24 hours, most of them, the risk is low, and they should come back and do, and the results should be durable, and they should do fine. Now, if you get a patient that is transferred to you on a ventilator in shock, on multiple drips, even if the mechanism is degenerative, the risk in that case is much, much higher, but then the risk of death is almost 100%. So what do the patients stand to gain from a MitraClip now? Is improved quality of life, decreased heart failure symptoms, increased energy, less fatigue, improvement in shortness of breath and such. And then also a potential improvement in, mortality, which means less risk of dying over the next few year period, which is very important also. So quality of life, length of life, and treatment of heart failure symptoms really is the benefits that patients will get. Again, that's why it's so important not just to clip what is sent to you with MR. Make sure it's severe. Make sure it's driving the symptoms. Really be confident in that. Otherwise, you're just doing a procedure with some risk that's going to have no benefit. And even if you complete the procedure, well done, the clip is on, but the patient won't feel better. And so all that needs to be strongly assessed. In our center, out of every 10 patients that is sent with mitral regurgitation, I would tell you maybe 2 to 3, maybe 4 might get a therapy. The rest will be treated medically. And many of those that are treated medically would not need treatment at all because the leak was not that bad in the first place.
So you have some patients that will need just one clip. Some patients may need more than one clip. At the end of the procedure, what are you try to aim for? 0 to very, very mild leakage of the valve, and what else are you looking in your parameters that tell you, well, maybe I need another clip in this case, or I'm happy with the results? What do you look at?
If you can do the case with one clip and get a great result, that may be ideal. But 1 to 2 clips in most cases is what's most common. Sometimes there's an advantage of the second clip, which is stabilization of the first clip, potential durability, further reductions in mitral regurgitation. And as long as you can put that on without increasing the chance of a tight valve, which is being monitored throughout the whole procedure, it's better, I would say, if you have mitral regurgitation and you got it down from 4+ to 2+ with the first clip, I wouldn't be happy with that. I would want to put another one on to get it down to 0 to 1. But, of course, make sure that the first clip was put on in the best way. I often see the first clip being put on and left there rather than it being moved and checked and appropriate. And, often that first clip can be moved to actually minimize the mitral regurgitation. But if you put that on and as a team in the room, you've decided that there's still a leak and you still like to treat it, it can be done safely, you shouldn't think twice. Put that second clip on, do it, get the result, great. The most I put on is probably 5. And those are for the very, very, very large ventricles. And you're essentially trying to bring the heart closer together in terms of size. And so 1 to 2 clips is definitely most common. There's absolutely nothing wrong with putting the second clip on to reduce the MR further if needed. It's not like it's particularly more risky, but it could be a better result if it's done in the right situation. And then, the more extreme cases might require several clips over time to be put on. And in some occasion, we'll, again, rarely, not all the time, but we'll say, what, I put this 1 or 2 on. I don't want to put the third one on now. I want to see how this patient does, because the third one may have some anatomic risk or affect the first 2. Let's send the patient home, see how they're doing. An integrated assessment using the pressures inside the heart, the color assessment, and all that. And then most of those people are doing absolutely fine when you bring them back for follow-up, and occasionally you bring someone back and put a third one on, and it gets even less, and they do even better. Again, not common, but you get to fight another day and do fine, rather than trying to do something that's dangerous or doesn't make sense in the first instance.
Obviously, the more clips you have, you're trying to bring those leaflets together to prevent the leakage, but you're also narrowing the valve and the opening across that valve. Obviously it's a balance. What kind of pressure gradient are you happy with after your procedure?
It is. You definitely don't want to trade no stenosis, which is, stenosis means tight valve, so no stenosis for severe stenosis. And if you are doing that, there's a number of maneuvers that can be used inside the room, such as speeding up the heart rate to see how that goes. But there are a number of technical things you learn over time to reduce that. I'll tell you about a case we had this last year where a normal gradient is 1 or 2. And when we start to get to 5, we start to say, okay, we're getting there now. And we definitely don't want to get to 7, 8, 9, 10, 11, So this was absolutely terrible leak in a patient that had had a previous surgery and had a ring on the valve. And everywhere we put the clip in this patient, we're getting beautiful grasps. And so it was soul destroying. So we're getting these great grasps, reducing the leak from torrential to nothing. But we'd get gradients of 15, 16, 17, and you cannot leave it. You're also looking at a patient which cannot have surgery because they're so high risk, and you're kind of stuck, and they're not a candidate for any of the contemporary mitral valve implant trials. So, on probably the 9th or 10th movement of that clip, we finally found one which got the gradient down to 7. And again, we're being very careful with all this. And then what we did is slowly open the clip. So not fully closed, but we opened it to around a 30-degree angle, which is allowed. And you can still, and the gradient went down to 5. And so it's a great case of just, simple maneuvers, maybe a little bit more advanced, but really careful working with your imaging team, understanding the technical components of the clip well, and being comfortable to have a lot of tissue in there and just open it a tiny bit. And that angle, so we came in with a torrential leak and an impossible case, but left with a, 1 to 2 plus leak. It wasn't 0, it was 1 to 2 plus. It was 0 when we had the clip closed. That was the worst thing. But the gradient, which was 17, which you can't live with, was down to 5, and the patient's doing great on follow-up. And so, those are the kind of decision. And I can tell you there's a lot of great discussion that happens in the room. That's why you want the best imager you can have in there, the best people in terms of understanding of this on the clip, anesthesiology that are helping with the kind of assessment and the pharmacological assessment of that, and then just the experience to know what to get away with. That's not a clip I would have wanted to do early on in my career with the clip, but it shows that even in the most complex of situations, you still can do complex clips, get a good result, particularly when you don't have another option.
I think if we look at the STS and all the gathering of all the clips being performed, they were looking at a patient population of about 3,000 patients. Everybody, there was like 4 plus MR or very, very severe mitral regurgitation. And after the clip, about 60% had just 0 mitral insufficiency to 1 plus, so very, very mild. And 93% had 2 plus MR or less, with success rate of 92% overall. Patients going home, 86% going home within 2 days, and very low mortality, less than 3%. And these are sick patients that are high surgical risk. So, overall, it's very good. And I think long-term, it's going to lead to really remodeling of the heart. And you see these volumes that actually become, the heart size becomes smaller, as you fix those leaks, and the heart function improves. So definitely a lot of benefits. We talked about the risk. We talked about the benefit. Let's see, if I'm a patient now that I was referred to you, I've had all this investigation. I've had my echo. I may have had a stress test. I had my MRI, my CT. So everything is ready, and it's finally decided. The heart team has decided a clip procedure is the right way to proceed. I'm being admitted next Tuesday. What should I expect as a patient? And how long does the procedure take? Looks like I'm going to go home possibly within 24 hours, maybe 48 at most. What should we expect?
The COVID era answer or the non-COVID era answer?
Well, let's say non-COVID.
Okay. So, again, the COVID era just adds another half a day before where you get the tests and nothing else. And so, let's say you're going for the clip, you'll be scheduled. You'll come in that morning at whatever time is designated. And let's say you're having a morning procedure. You'll meet the anesthesiologist again, if you've not met them already. And you'll go to sleep and you'll be taken to the room. So the room will be prepped. The area is through the femoral vein where we go through most of the time. And that will be prepped. But when I say that, I mean the cleaning and sterile chemicals are put on there to make it sterile. So you can't get infection from that, to minimize infection as much as possible. At the same time, you'll be being given medications by the anesthesiologist to put you to sleep. A breathing tube will be put in. And, this is good because you feel no discomfort at that point. And so then the procedure, getting ready for the procedure, that whole process takes about 30 minutes. And then you'll get a message saying the patient is draped, and you'll go in, but your imaging specialist would have already been in there obtaining images. And you'll spend a few minutes re-reviewing the images, making sure everything is as advertised, making sure you're confident to go ahead, and just a third layer of checking after all the pre-procedural checks that have been done before. So then you go through the groin, tiny needle called a micropuncture needle used to introduce a wire, and it's called getting access, and that will get you into the femoral vein through which we are going to go up to the heart. A wire will be passed through your leg, up through the body, into the heart chamber, and then we'll go from the right chamber to the left chamber in a process called a transeptal puncture, which is guided by the echocardiogram. And ultimately, we'll put this thing in, this tube called a guide or a delivery system into the left chamber, which is where the mitral valve is. And through that, we'll put the clip. The clip process can take anywhere from, for a very experienced team in a straightforward case, 30 minutes, 20, 30 minutes, faster if you can. But again, the goal is not to do this as fast as possible, it's to do a good job. And in the most challenging and extreme of cases, several hours in the room. But then when the procedure is complete, assuming all has gone well, the clip tubes and everything are taken out, and we use a little suture down in the leg just to tie that together. And the patient is woken up and the breathing tube taken out in the room in almost all elective cases, so all cases coming from home. The patient is starting to wake up in the room and will be awake by the time in a few minutes later when they get back to the holding area. The patient will then go to the floor. So let's say you came in at 7 a.m. and your procedure is done by 10 a.m. After prep and everything being ready, you'll go to the floor, and by 11 o'clock or 10 o'clock, you'll be on the floor, which is an outpatient, which is a room on the floor of the hospital, not an intensive care unit. We don't do that anymore. Everyone did that at the beginning because we still felt this was, heavy-handed procedure. But now, very, very rare to send a patient to an intensive care unit, particularly when they are extubated, which means the tube can come out. So then the patient can get up after a few hours, sit in the chair, walk around. They've still got that little suture in their leg, which we usually take out the next morning. And, the next frontier will be, can we send patients home the same day? This will have to be studied. I mean, we've done it, and, cases that are absolutely where it's forced. But, as of this minute, we still feel there may be an advantage to watching overnight. The next morning, we get an echocardiogram. First thing in the morning, 7, 8 o'clock, someone will come across the room. We're looking for no effusion around the heart and stuff like that, no evidence of damage. But we want to make sure the clip is stable, the clip looks good, the leak is still reduced. And then you say, you go and in pre-COVID, you used to shake your patient's hand, right? Post-COVID, you look at your patient and say, hey, this is great. The clip looks in great positioning, the leak's all the way down. And often they'll tell you they feel a lot better already. They'll be up and about already, and you sign the paperwork and send them home. And that's about a 24-hour process. They'll come back to you at 1 week. But nowadays we just do a televisit, and you'll just make sure everyone's doing okay, no issues. And then you'll say, really go for it. Do what you want at this point. No limitations at all. And then at 1 month, we'll check the clip, the valve, the heart, make sure everything's okay, and then medication adjustments as required and other answering of questions that patients have. It's good practice for patients after procedures such as the mitral valve clip to go to cardiac rehab just to get more supervised exercise, conditioning for many of the older, frailer patients, and just the confidence to get back and do what they want to do. But the reality about the clip is, the day after the clip, you should be able to do almost all you want to do because it's such a low profile. If it all goes well, stress on the body, you're not stopping the heart, you're not stopping all this stuff. And so you should be able to go forward and have a very, very fast recovery. One of the very attractive features of the MitraClip. And
actually, the risk of complication requiring emergency surgery is very low. Probably, is it about less than 1% or 2%? Or?
Yes. I mean, we do very challenging cases and ones that are higher risk. And despite that, the risk of having to go to emergent surgery is very low. I mean, you never want to go from the clip room to the operating room, ideally. I mean, even if there is some complication like that, the ideal situation is a stabilizing period, discharge, and come back for that. If you have to go for true emergent surgery, which means there's been an immediate complication, that's why you want a good heart team with excellent surgeons that can get people out of trouble when that happens. But the risk is very, very low. I would believe that 1 to 2% figure.
So results are very good acutely. What about long-term results? I mean, it seems like some of the clips that were placed for secondary mitral regurgitation patients that had, sicker hearts had maybe a little bit more procedure within that first year. But it seems like after that, it was really good. So what kind of long-term results do we have? And if we do have an increase or a problem with the mitral regurgitation, the leakage becoming more severe, can you go ahead and put another clip in 6 months or a year later?
You absolutely can go back in and put other clips in many situations, not if the leak is to do with the first clip. So sometimes for technical purposes, the first clip being placed really makes it difficult to put a second one on because you can put a second one on, but it won't be taking care of the mechanism, which will be related to that first one. So those are situations which are unfortunate. But and hopefully for the most place avoidable. But you can, for example, you put a clip here in the middle and a little leak to the right of it comes on. You can go in and put a clip to the right of it, and that can, as long as the valve's not too tight and the patient's an appropriate candidate, you can go and put a second one on to good effect. And it can be done with the same very low risk and can get good results. But when you talk about how durable is this, we do have data from many registries now coming out of Europe and the United States to demonstrate that, all the way up to the 5-year point, you can have good durable results. They don't get tighter over time. The leak doesn't go outside that 2+ range to severe more. And the more data we get out, the more data there is to suggest that these are durable things over time that can last the length, in terms of over the long term. You do worry a little bit with the explosion of MitraClip and MitraClip centers. Remember, when we do these trials, we're choosing sites that have done a lot, that are very proficient in what they're doing and that have expert teams in there. When you suddenly exponentially grow that, and there's a whole debate going on right now with the CMS, and it's actually the end of the open comments period just recently, where people are debating this. Where should this be done? How should this be done? Who should do it? Should it be someone who's had adequate training, or should it just be in a center that does a lot of these and seem well positioned to do those going forward with a lot of backup? And if you restrict it too much, will you be denying people in certain places therapy? But if you don't restrict it enough, will you be worsening the results and diluting the results over time and putting people in more danger? No easy answer to this. It's often patients can help inform their own decision, and local teams will, have their decisions. But this is everything in medicine, as it is. But, depending on registries are important over time. And hopefully there's data that continues to be collected in registries to monitor this over the long term and ensure that the results stay good over time.
Certainly in the structural and in the surgical world, number of procedure does matter. I mean, you want to go to a center that's very proficient in these procedures and do a lot of very experience with it and have a large patient referral. And I remember when we were back at, a few years ago, where you had done your 100th, clip. And I'm sure that, since you're at UAB, your center is putting, a lot of clips and appropriately, because, you have an incredible team. The heart team approach has been implemented very well at your center. What's the future for the clips, Mustafa? You already mentioned that you have the new clip design, the G4NT and G4XT, which allows maybe to grab a little bit more of the leaflets, which may be useful in flail. What other technology is out there?
I remember the good old days. Do you remember that 100th? That seems like such a faraway milestone.
I think that was a tweet.
I remember those good days. We've done several hundred now as a team, and it continues to grow. And I guess 1,000 is the next kind of milestone for that. But the clip technology is changing. It's changing for the better. Right now, we have 4 different types of clip we can use in this new system called the G4. NT is the shorter one, and XT is the larger one. And then you have NTW or XTW, which means larger and wider. So the wider clip's allowing us to catch more tissue, potentially improving durability, potentially decreasing the number of clips. And we are actually, data is coming out on that in the next month or two. We just finished working on publications to that effect with the G4 working group. And I think it's been a great advance in technology. You can do independent grippers. So you can do the anterior one first and then catch the posterior one after that. It certainly allows for an increase in complexity of what can be done. And then these registries that are coming out will demonstrate the safety and efficacy of those. But having been involved in, amongst the very first implants of those in the United States, actually in the world, we've been impressed from minute one with how they're going. And it seems set that they're going to become the gold standard going forward. So have definitely been impressed with that.
What about the clasp versus the clip?
Yes. So clasp is the name of a trial. What's the device? It's called a Pascal device.
Pascal device.
This is done by, it's never a bad thing to continue to have increasing technologies available. Like with every other technology, for that, trials are ongoing right now to look at the safety, efficacy, and results that can be achieved. And in a few years, hopefully, when those trials are complete, we'll find out if we have, more than one technology available. I'm not as familiar with that, but once the data is collected and shown, we'll find out what the different types of clips and what can be used best in which situation. Hopefully, within a few years, we'll have the results of those.
Be great. Well, Mustafa, thank you again. That was a very comprehensive review of the data on the MitraClip for mitral insufficiency. Such an interesting topic. In our next podcast, we'd like to discuss maybe more the surgical aspect of repairing or replacing a mitral valve when it's leaking severely. And also, we want to expand a little bit on the secondary mitral insufficiency, because the medical therapy or maximal medical therapy has changed quite a bit, has evolved. And, I think we have to be really mindful that the clip is really given in addition or in combination with the medical therapy. So I think it would be good to reconvene and discuss specifically, the context of secondary mitral insufficiency when the left ventricle is sick and large. How can we help best with medical therapy, sometimes combined with clip? Another topic for a future podcast.
And, one thing in the future we can discuss is also the transcatheter mitral valve replacements. Mm-hmm. Those are really coming into the fore. We've got a good bit of experience with those now, and it's each step is mind-blowing, isn't it? I mean, it's amazing how fast. I mean, technology is progressing at a much faster pace than we can actually keep up with in terms of evidence, operator experience. I mean, it seems like someone's trying something new every day, new company. It's really good for the field of valve disease. For the longest time, like you said, this has been exponentially growing. With the aging population, it's a public health issue. The options have been minimal over time. And it will be great, in the next 10, 20 years, where we just have a fluid number of multiple treatments where valve disease can be taken off the table as a risk factor.
That's wonderful. Future is bright. It makes me feel better as I'm getting older with my mitral valve prolapse. I'm going to have so many options.
You're still a very low risk candidate. Still open surgery for you, I'm afraid.
Well, thank you, Mustafa. We'll talk to you in our next podcast.
Bye. Thanks.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.